Hello, I'm Rahul, a junior doctor in the UK, and welcome to ECG Reviews. Today we have an interesting case of a 30-year-old male with right ventricular hypertrophy. Let's examine this ECG using a systematic approach including rate, rhythm, axis, hypertrophy and infarction. Let's begin with rate. So we pick two of the same spot and we see that there's 1, 2, 3 large boxes. 300 over the number of large boxes is the rate. So therefore we see that this patient is borderline tachycardic. Now rhythm involves two things, and that's the PR interval and the QRS. PR interval ranges from there to there, which is about 3 small squares. Since one small square is 40 milliseconds, we have 3 times 40, which is 120. Now as long as the PR interval is less than 200 milliseconds, we're happy. The QRS ranges from there to there, which is about 2 small squares. 2 times 40 is 80. Now as long as the QRS is less than 120 milliseconds, we're happy. So therefore the PR interval is normal and the QRS interval is normal. Now let's move on to axis. So first we're going to draw our circle. Now remember, the most important leads are leads 1, 2 and AVF. Now if we have a look at lead 1, the R wave is small and the S wave is large, so therefore lead 1 is negative. Now lead 1 points towards the left, so if it was positive we'd shade the circle in the same direction. However, since it's negative, we're going to shade the opposite side. Now lead 2 is also negative. The S wave is greater than the R wave. Lead 2 points downwards and towards the left, so we're going to shade in the opposite direction since lead 2 is negative. Now this area of overlap is where the axis lies. So as you can see, the axis lies between right axis deviation and extreme. So we'll call this severe right axis deviation. Now this is not normal, so we have to wonder what the reason behind it is. The first one is it can be normal. For example, in children the right ventricle predominates, so we often get right axis deviation. Also in thin individuals the heart is rotated towards the right, giving us right axis deviation. The opposite is also true, so in particularly obese individuals the heart can be rotated towards the left, giving left axis deviation. The second is COPD. Now in COPD you also get low voltage QRSs in the limb leads, which means less than 5 millimeters. 5 millimeters is one of these boxes. 3, we have a lateral MI. Now if you think about it, a lateral MI will wipe out this entire portion of the heart, so therefore this becomes electrically inactive. So the wave of depolarization is now shifted towards the right, giving us right axis deviation. 4 is right ventricular hypertrophy, and 5 is a left posterior fascicular block. Now this isn't particularly common, so I want you to consider this low down on your differentials. Now let's move on to atrial hypertrophy. So the most important thing to understand here is that the SA node is located in the right atrium, and the impulse travels towards the left. Now when the left atrium enlarges, this distance becomes greater, so therefore the P wave starts to prolong and it becomes wider. Now once this distance is more than 120 milliseconds, we say this is suggestive of left atrial enlargement. If we have a look, the P wave starts here, ends here, and that's about 1, maybe 1.5 squares. That's between 40 and 60 milliseconds, so therefore this patient doesn't have left atrial enlargement. Now for right atrial enlargement, we look at the amplitude of the height. So we go from here to here, and we see there's about 3 small squares, which is 3 millimeters. Now anything greater than 2.5 millimeters is suggestive of right atrial enlargement. So therefore this patient's ECG is very suggestive of right atrial enlargement. Remember, ECGs can only be suggestive. These diagnoses have to be confirmed in an echo. Now let's move on to hypertrophy. So we'll start off with the left ventricle. So the criteria for this is the S wave in V1 plus the R wave in V5 should be greater than or equal to 35 millimeters. If you have a look at V1, we see that the S wave is very small, maybe 1 or 2 millimeters. In V5, the R wave is very small again, 1 or maybe 2 or 3 millimeters. So therefore that's about 4 millimeters in total. Therefore the patient doesn't meet this criteria. The second criteria is that in AVL, the R wave is equal to or greater than 11 millimeters. If we have a look at AVL over here, we see it's probably about 1 millimeter, so the patient doesn't meet this criteria either. Now for right ventricular hypertrophy, there's two things. So in V1, the R wave is greater than the S wave, and in V6, the S wave is greater than the R wave. As you can see, in V1 the R wave is massive and the S wave is small. In V6 we see that the S wave is slightly larger than the R wave, so we meet both criteria. Now one thing to mention is that the RS ratio in V1 isn't specific to right ventricular hypertrophy. It can have other causes. For example, it can be normal like many things. Second, it can be a posterior infarct. So if you remember from the posterior STEMI video, posterior STEMI actually presents with ST depression in V1, so you get the opposite finding. So similarly, a deep Q wave posteriorly will show as a large R wave in V1. 3, we have pulmonary problems. So for example, a pneumothorax or a pleural effusion. So if you think about it, let's say the patient had a left-sided pneumothorax, that would shift the heart to the right. Now V1 generally looks at the right side of the heart, but actually now it will start looking at the left and you get a tall R wave. 4 is Wolff-Parkinson-White. And of course 5 is right ventricular hypertrophy. Now one thing to mention is that you can differentiate right ventricular hypertrophy from posterior by looking at T waves. Generally in a posterior infarct, the T waves are upright in V1. And in right ventricular hypertrophy, you have T wave inversion in V1. So that's one easy way to have a look at to see whether it's right ventricular hypertrophy or a posterior infarct. Okay, so now let's move on to infarction, which is composed of 3 things. The first is Q waves, the second is ST changes, and the third are T wave changes, particularly T wave inversion. Now the first thing to understand is that we're looking for pathological Q waves, which are greater than 40 milliseconds wide, or greater than 1/4 of the QRS amplitude. So if we have a look in lead 1, this is actually an S wave. Remember, the Q wave is the first negative deflection. There's actually a small positive deflection here, so therefore this is an S wave. So no Q waves in lead 1. Lead 2 we have no Q waves, and in lead 3 we have no Q waves. Now for ST changes, the proper way to work it out is to find the J point. So the J point is here, and we go 2 squares along, so about there. And we compare this to the ST segment. So again, probably no significant change. In lead 2, we see again no significant change. Lead 3, again no significant change. Now with the T waves, we see that in lead 1 they're upright, in lead 2 they're inverted, and in lead 3 they're inverted. Now an isolated inverted T wave in lead 3 can be a normal variant, but if it's also inverted in lead 2 like here, you should consider other causes. Now let's move on to the next 3 leads. So again, Q waves, no Q waves in AVR. AVL, this is an S wave because we have a positive deflection. Remember, Q wave is the first negative deflection. Any positive deflection and it's an S wave. AVF, again, no Q waves. ST changes, again, AVR, no ST changes. AVL, again, no ST changes. AVF, no ST changes. In terms of T wave, AVR is flat, AVL is upright, and AVF is inverted. Now we're starting to see a common theme, so it appears that the inverted T waves are present in the inferior leads, which if you remember are 2, 3 and AVF. Now let's move on to precordial leads. So we'll start with V1 to V3. So in V1 we see this could be a Q wave, but actually if we look closely we see that there's a small positive deflection. So therefore this is actually an S wave. Now something interesting to note is that actually in V1 we have a small R, a small S, and a second R wave, so we actually have an RSR pattern. Now normally if we have an RSR pattern plus a QRS greater than 120, we should consider right bundle branch block. But in this case we don't have a QRS greater than 120, so we call this an incomplete right bundle branch block. So that's our first diagnosis that we've got. Now if we have a look at lead 2, no Q waves. So remember, V1 no Q waves, V3 no Q waves, ST changes, V1 no changes. But if you have a look, you can see that there are down-sloping ST segments in V1. V2, if you have a look here to here, there's some maybe about 2 millimeters, 1.5. Now generally ST elevation is significant in most leads if it's more than 1 millimeter, but V2 and V3 are the exception. It must be greater than 1.5 millimeters in females, greater than 2.2 millimeters in males that are over 40, and greater than 2.5 millimeters in males that are under 40. Now if you remember, this patient is 30 years old, so therefore they don't meet the criteria of any ST elevation in V2. V3 again, similar story, not much elevation. Some places you could probably say that there's probably 1 or 2 millimeters. T wave changes. We see that there's an inverted T wave in V1, inverted in V2, and inverted in V3. So we start to see a pattern. The right-sided chest leads have T wave inversion, and the inferior leads, 2, 3, and AVF have inverted T waves. Now let's move on to V4, 5, and 6. Again, no Q waves. ST changes, V4. Probably make the argument that there's maybe about a millimeter. V5. Again, J point is there, so we go two squares along, and then we go to there, which is probably maybe 1 millimeter if you're generous. V6, no change. Now, whenever you have ST elevation, you should consider the wider picture. So in this case, by now we've examined all the leads. We've not seen any ST depression, so we've not seen any reciprocal changes. So therefore, these changes are likely to be insignificant. Now let's have a look at the T waves. So in V4, you can make the argument that they might be biphasic. V5, probably normal, and V6, certainly upright. Now let's put this all together. So, for rate, we have 100 beats a minute. For rhythm, the PR interval was less than 200, which is normal, and the QRS was less than 120. The only other thing to check is that, is it a sinus rhythm? Remember, sinus rhythm means that the rhythm is originating from the SA node. So we have a look and we see if the P waves look the same. If they look the same, they're originating in the same place. Secondly, we see if they're upright in 2, 3 and AVF. 2 they're upright, 3 they're upright, AVF they're upright. So therefore, this is a sinus rhythm. Next, we have axis. So we have severe right axis deviation. So we've done rate, rhythm, axis. Now let's move on to hypertrophy. So we saw that there was evidence of right ventricular hypertrophy and right atrial enlargement. Because remember, the P waves were taller than 2.5 millimeters in lead 2. So rate, rhythm, axis, hypertrophy. Let's have a look at infarction. So we saw that there was T wave inversion in V1 to V3, plus the inferior leads, which are leads 2, 3, and AVF. We also saw downsloping ST changes in V1. And finally, we had our other diagnosis of incomplete right bundle branch block. Now, putting this all together, our final diagnosis is right ventricular hypertrophy, and all of this will start to make sense. So the right ventricular hypertrophy, eventually you'd expect the patient to also develop right atrial enlargement. They'd also have right axis deviation from the right ventricular hypertrophy. Now, another finding that's commonly associated is that there's T wave inversion in V1 to V3, 2, 3 and AVF as well. And there's downsloping ST changes in V1, which is also typical. Now, something else that's associated is this right bundle branch block. The right ventricular hypertrophy can cause it. So often whenever you get dilation or hypertrophy of the right ventricle, you get an incomplete right bundle branch block. For example, in a PE, the right ventricle can be acutely dilated, so you can often get an incomplete right bundle branch block in a PE as well. Okay, so that's the end of the video. Thank you very much for listening. If you enjoyed this content, please subscribe as there'll be more coming. Thank you.